Hi again, everybody. So, yep, Dr. Mignot and I are here to talk to you about what things that you should know about narcolepsy. And with the best doctor who knows the most about narcolepsy in the entire world. And myself, I myself have had narcolepsy for over 30 years. And so I have seen the whole narcolepsy world change and grow and get better. And I've, been an advocate for myself and the narcolepsy world for a very long time. So it's hopefully we both have some information that can help you. So one of the things, I'm just going to tell my story briefly, quickly, and then we can, we'll chat and hopefully help you. But so I was diagnosed like 25 years ago. And I know we've heard lots of stories from everybody, and I can relate to all of them, as you all probably can relate also. But I was a normal kid, played lots of sports. And then when I got to college is when I started falling asleep everywhere. Nobody knew what was wrong with me. When I looked around, everybody else was sleeping. So that was totally normal. After I turned professional, I was a golf pro. I played golf in college. And then after college, I turned professional and I got on the LPGA tour. And so the LPGA tour is like the highest level in the world you can play. I don't know how I did it, but I did. I was a hard worker and I just did it. I was very sleepy driving across the country playing, falling asleep on the golf course and just falling asleep with sponsors, falling asleep everywhere. Nobody knew what was wrong with me. I went to many doctors and they told me to, not work so hard. Anyway, eventually I developed full cataplexy. So after developing full cataplexy to the ground, we realized there was something wrong with me. I really thought I was going to die. But there was a doctor that listened to me, and he was just a general practitioner. And he said, I think you have narcolepsy. And then he told me what that was. And I was like, oh my gosh, I have all of those symptoms forever. So from that moment on, 25 years later, it's just been a roller coaster ride. And so I've learned a lot. I've met hundreds of people with narcolepsy. I've learned all the medications, except for the current ones, because I don't know those yet, because there's so many new medications out there for us. Back when I was diagnosed, there was nothing but amphetamines. The world has completely changed thanks to sodium oxybate, Xyrem, and it changed my world. It changed the world for a lot of people. Conferences like this, everybody used to sleep at, and now we are awake. It's amazing. So thank you, Dr. Mignot, for all the research that you have done that has helped all these drug companies come up with medications that are helping us stay awake. And there's so many out there now that are on the horizon. I'm on a newer one as well. And you never want to stop trying to feel better. And so I'm even going to try another one after coming to the conference. I've learned about another one. So maybe that one's going to help even more. Who knows?
Yes, I agree with the idea. I often say for narcolepsy, it's very important to try things because, until you try, you don't know if you're going to be better. Everyone is different, and sometimes medication can help some patients, others less. I can only, advise, but it's not like other disorder where you can try something, even Xyrem, and sometimes it doesn't work for everyone. But then you stop, and this is usually not the end of the universe. You have still to do it carefully, but it's not like you become as you were before. It's not like some of the disorder like depression or schizophrenia, where you always worried, if you stop medication and someone becomes completely crazy, then they go to the hospitals, they never completely recover. It can destabilize people. But for narcolepsy, generally, if you change a drug, you stop drugs, they just become narcoleptic again. That's pretty much it, but it's not like something irreversible. So I think it's very important for you guys to never hesitate to try different drugs so that you have a good baseline. And if you don't like them, That's totally fine. I mean, I always tell my patients, I work with you as a partner, and I'm going to listen to how you feel. And
Yes,
that's very
and very, very important to find that doctor that's going to listen to you, the doctor that has the experience. That is the single most important thing, is to find that doctor that's going to help you. And I went to many doctors before I found my doctor in Houston, Texas. And the only reason I found him was because I was playing in a golf tournament there, and I couldn't drive from where I was staying to the golf tournament. And the man I was staying with said, my best friend's a sleep doctor. You should go see him. And I was like, yeah, right, whatever. Everyone thinks they can help me and I'm just sleepy. But I went and I met Dr. Todd Swick, and he changed my life. And he listened and had experience with people with narcolepsy. He knew what to do with me. And so that was the point that I started feeling better. So if you don't leave here with anything, the most important thing, if you have narcolepsy, is find a doctor that is going to listen to you. They will help you.
And be wary of doctors who know too much, or that say they know too much, and be wary of doctors that don't know anything, because that's another problem. I've seen everything. I've seen patients that were prescribed Xamarin during the daytime. I mean, I've seen everything. I can tell you, I've really seen everything. So, doctors are not God. And I would also say that, even myself, I'm not perfect. You all, learn from every patient. And, sometimes I try what I think is the best based on my experience, but sometimes it's not what worked the first time. And there's definitely in my mind, like a couple of patients where I just hate myself because I don't think I did what would have worked probably the best, and
yeah, and it's okay. Like I remember the first time I was prescribed Xyrem was from a doctor in Chicago, and he was trying. He really was trying, and he did what he thought was the best, and it did not work out for me at all. But then later again, I hooked up with somebody that had more experience than my local doctor, and it was just he had to learn too, and he knows now. And I was, we got to learn. And so I'm sure that he's now prescribing great medicines for lots of people that he's helping. So.
Yeah, and I want to also mention one thing about what you said is I've seen the field of narcolepsy when I first started. So there were already very good studies that I found that narcolepsy affects about 1% for 2000. In fact, when the first study was published by Dr. Dement, my predecessor, who kind of was a graduate student when he discovered REM sleep. And he was very interestingly, he did like an ad. He was very interested in narcolepsy because he discovered REM sleep. So it was kind of related. So he did an ad in a newspaper about if you have these symptoms, when you laugh, you collapse. And then there were a control ad, I don't remember, but asking for something different. And then he compared, the results, and he kind of figured out what the prevalence of narcolepsy, and he came with this number, 1 for 2000. And actually now it has been done in Korea, in Europe, in China, I think probably 50 times. And it's about that, between half of that, 1 for 3,000 to 1 for 2,000 for the patients that are clear, that have cataplexy, not without narcolepsy. But at the time, when I started, people were telling me, I don't know, anyone with narcolepsy. All the neurologists were telling me, I've never seen a patient with narcolepsy. So since it's relatively common, clearly they missed them, and I had patients, even very famous people, neurology, very famous university, telling me that narcolepsy did not exist in kids. There's just kind of, there were a lack of education about narcolepsy. This changed a lot when we found the cause of narcolepsy in dogs. Suddenly that became so the science, I know that you all, I'm preaching to the choir, but I believe that scientific achievements also make a big difference because they also put it on the map, for everybody else. And finding the gene for the dog narcolepsy, suddenly a lot more people started to be diagnosed with narcolepsy, and we started to see the kids. Before, I was never seeing any kids, never. And then we started to see the kids because now narcolepsy became more known, and we started to see that the kids were not behaving the same way. And that they have slightly different symptoms when they start because they gain a lot of weight, they have a lot of mouth opening. Sometimes it's slightly different, and we learn about the kids. And then when we discovered, of course, the lack of orexin in people, that also made a big difference. And now we are in a new phase where I think we're getting completely new treatment, and that's going to also bring a lot of new people who are not diagnosed and don't know. I'm pretty sure that there are a lot of people like Nicole who just, they didn't really realize that it could be a disease or something. Actually, I can tell you another story, which shows that it's not so rare. I mean, one day I was interviewed by someone like many years ago by an Australian TV crew. And it was on weird disorders, something like that, a little sensational. I'm not very proud of that one. But anyway, I did it. And then I explained everything about narcolepsy, that people dream a lot, they go in REM sleep, etc. And cataplexy when they laugh, And then the guy had the sound, the sound man, he had this microphone like this. And then I saw it was becoming completely white, It's a little strange, he's going to faint. And then after he just lowers his microphone, he said, "Oh, I think I have your disease, doc," And he had everything, cataplexy, etc. I immediately proceeded with taking a blood sample, of course, for my research. And he was actually positive. He had all the symptoms. And what I feel bad is after the whole crew was mocking him and so forth. So that was bad, but at least he knew what he had. But I mean, he was 40 years old. He was overweight. He didn't have any idea.
Yeah, nobody ever talked about it. And nobody talked about narcolepsy really until we knew that you proved it and proved what was wrong.
And even when we started, like people thought it was psychological. I was trained as a psychiatrist, and I even did a psychoanalysis. Can you imagine, like with Freud and all those things? It didn't help that much. I'm still as crazy, but it would still help I think, self-awareness, and it made me certainly a better psychiatrist for sure. But what was interesting is that, I started to work on biology and to realize the cause of the disease, and it's clearly organic. It's not like there is psychology, because we heard very nicely that narcolepsy doesn't occur in a vacuum. It happens in a very real person, but the way it manifests is going to be very different depending on the person. But at the same time, it's a biochemical defect. It's not like, there's really a clear cause, there's no doubt. And I had one of my other good friend who did psychoanalysis, and I was already discovering the HLA associations and the gene in dogs. I knew it was genetics, I was looking, and, I met him back in France, and he said, "Oh, yes, but, this narcolepsy, are you sure it's not a flight reaction?" I almost, my jaw dropped. I almost had cataplexy, I said, "You are crazy. I mean, this is really there is a real biochemical cause. There's no doubt. Even dogs have it. It's not like they are repressed sexually, or at least not this one." He's intact. But anyway, so that was, it shows you how it was, like maybe 20 years ago. And I mean, we made a lot of progress. We still have to make progress. There's probably about half of the patients in the US that are underdiagnosed. There are certainly other countries where it's a disaster. I mean, I think England's are less diagnosed. I think, of course, in Africa, can you imagine? In China, I met Dr. Fan Han in 2004, and he didn't know even it was pulmonary medicine, didn't even know cataplexy. And I told him about the antidepressants, etc. And then now he has about, 7,000 narcoleptic patients, type 1. So China now is like super developed in narcolepsy. And in fact, they are probably going to do a lot more research than us. We're probably going to be passed by them because they have so much more funding and so much more patients. But for example, in India, I went to India. I tried to do the same thing, collaboration with India, because I'm sure there's many narcoleptic in India. But somehow in India, the review of the first research project that I did, they say, "Oh, at Stanford, you're trying to steal all the blood from the narcoleptic patients in India, and you don't, and then it was not approved even. So I was going to pay for the research to help them. And as a consequence, no one is diagnosed in India. So it's kind of interesting to see how, little things can make a difference. That's another thing I would just advise you in life, just remember one person sometimes and one encounter can make a big difference. I met this guy in China. I actually met a journalist who got very interested in narcolepsy, put it on the web and said, he diagnosed tons of people in China. And now China is quite evolved, but they don't have all the treatment. So anyway, we have to do still a lot of work for diagnosing patients.
But we're on our way. I mean, my gosh,
Yeah.
it's just, I can't, I mean, I'm very involved and I had no idea about all the medications and things that are on the horizon. So, it's very exciting. We're in an exciting time and, for narcolepsy, we're so lucky to, have all these resources. So,
I was wondering, did you have cataplexy when you were putting?
usually when I hit the ball or if I made a long putt. Yes.
Long putt.
Yeah, if I made a long putt, anything that was unexpected, if I made a long putt that, was unexpectedly going to go in, I would have cataplexy. And then the crowds would clap and then I would have to take a minute and then get my emotions back under control and then I could wave. Always a delay.
Yes.
Yeah, but I'm better. I'm a lot better now. And so now I could probably even win the tournament and not have cataplexy. But for many years, my cataplexy, I had to keep my emotions very evenly controlled, which actually kind of helped my golf game. It really did. And then I had to visualize my shots always being perfect and always being in the hole, because if I didn't expect it or want it, then I would have cataplexy. So it was really kind of it kind of helped.
Cataplexy is also something very mysterious. I mean, I spend a lot of time teaching my doctors about cataplexy because not everything is cataplexy. And it's a very important symptom for narcolepsy type 1. And it's always very personal. It's something that deeply moves people in a certain way, even so it's usually laughing and joking, but humor is very particular. I mean, some people are sarcastic humor and that's what works. Sometimes and then other time it's just something else. It's very personal, but at the same time stereotyped. So it's really fascinating symptom. We don't really completely understand why the lack of orexin causes this very odd association between something that's funny, something that's pleasurable, amusing, but really personally. And indeed, with a component of expectation is also important. Often it's just I'm going to get something, or I'm going to succeed, or a little bit unexpected. It's very, so that's why when you know a lot about it, you really recognize it. Like the patient, they give you a story. There's really you don't even have to do a test. In fact, the sleep test is totally useless, but we still do it because, because it's nice to have an objective way. But it's also dangerous. Sometimes people don't have a positive sleep test. As I mentioned, it's like a few percent, maybe 8%, but it's not negligible. So clinical picture is very important. But now, I mean, as you said, another big turn was Xyrem, which now is getting another very big turn. Is even myself, I had not realized for many years that Xyrem can help people with idiopathic hypersomnia. For a long time, we were really reserving it for narcolepsy. And one of the problems with Xyrem, it's not perfect. It works incredibly well, but it does produce sometimes psychiatric symptoms. It's not what's written on the label, unfortunately. It's always something else that lawyers have made up. So but sometimes, people get more anxious, and sometimes they really develop severe complication, depression, very weird complication. And initially, I discovered relatively quickly that a lot of these patients, if you add a little bit of antidepressant, a tiny bit of Prozac, it goes away completely. So for a while, I had also, after Xyrem, I discovered this. I started to realize first that was super effective in kids, really almost more effective than in adults. And then I discovered that for people who don't tolerate it, sometimes adding a little bit of antidepressant made a huge difference. And it's amazing. I even had people who didn't tolerate it and didn't feel good with it. And I really restarted and put a little bit of antidepressant, and boom, they were completely transformed. So that made it much more tolerable. And we learned a lot about other things you can add with nausea. You know, I have certain tricks with nausea. So, I mean, that's, you know,
That's why you need a doctor that has some experience and success with treating narcolepsy.
No, that is
Yes.
true. But so we learned a lot on how to make Xyrem more tolerable. And let's say that initially, you know, 50% of people would tolerate it. Now I would say like 80%. And I would say most are really transformed by Xyrem. But now we are also discovering that people who have idiopathic hypersomnia or narcolepsy type 2, there's a good numbers that are really also transformed by Xyrem the same way as patients with narcolepsy type 1. And I have to say, initially, I was not so sure for many reasons. One is, you know, first, there were all these psychiatric side effects. And I think I told you that some of the narcolepsy type 2 idiopathic hypersomnia, sometimes, you know, there's a relation with depression and so forth. So you're kind of, I was worried that it could really decompensate a lot of these people, but now I use it quite a bit. And when they are on antidepressant, the same way, it's not really that bad. And some of these is like completely transforms them, you know, the same way as narcolepsy type 1. So I can't really tell you again how important it is to try medications, you know. So that's, I think, a new development that we're realizing that Xyrem can be very effective for narcolepsy type 2 and idiopathic hypersomnia as well. And then now, of course, there's these new drugs that replace orexin, which are totally different game changers and just much more effective than narcolepsy, than the old stimulants and the antidepressants. They also work on cataplexy. The real question is, are they going to be sufficient? You know, is it going to be good enough, or do we want to add a little bit more things, like a little bit of Xyrem at night, etc.? I suspect that a lot of patients will still benefit from those plus a little bit of something, but a lot of people will do fine with just orexin agonists. We have, I certainly now have experience with a lot of patients on clinical trial, and they are doing very well. So it's going to be, and they think it changed them in a different way. You know, like if you're on Xyrem and all these drugs, you still have narcolepsy, and often there's this limitation of life that remains. I don't know, but I'm sure some of you experience that. It's just you can't be effective, you know? It's kind of like, it's harder to do things because you have to plan sleeping. It's harder for people to go outside of themselves and be a little crazy. I don't know how to say this better or more adventurous. And you really see that a lot in patients with narcolepsy. They self-limitate themselves, and that's because they're not treated perfectly. And with this new drug, I really have seen like that I've not seen before. It's like people really change their life, you know, and the way they reacted, like puts them to another level where they were more daring, more, you know, really because they were actually treated correctly. So there's some room for improvement. And I think I mean, you should be really happy that we live in such an incredible period of time. We have to be a bit patient. We need probably a few more years until this drug will hit the market and everyone will be able to play with them. But I'm sure you will try.
I will. You always have to be willing to try.
Yes, absolutely. Yeah.
And not just medicines, but, you know, like taking care of yourself and eating correctly and drinking a lot of water and, you know, support and advocate exercise. All these things really help.
Exercise for patients with narcolepsy is just incredibly important. It's important for a lot of people, but with patients with narcolepsy, I've discovered that it's almost therapeutic, you know, and if you don't exercise, a lot more difficult to live with narcolepsy. It's important for everyone, but there is definitely a vicious circle. When you gain weight, it becomes worse. And we don't really understand it completely, but exercising is really also very strong medication for patients with narcolepsy. But of course, you know, it's difficult because sometimes you tell people to exercise and I'm too tired to exercise. I don't have time. And, you know, you understand all these things. It's not like easy to, you can't prescribe a pill of exercise, you know, unfortunately. Otherwise, I would take it tomorrow. You know?
I will say I used to work out all the time and now, you know, at the gym, I was in very good shape and I felt really good. And now I have a full-time job and I don't do that anymore. And I don't feel as good as I used to. I mean, I did add another medicine that's helping, but it's like Band-Aiding. I mean, really, I should get back in that gym so I can feel better. And now hearing Dr. Mignot talk about that, I mean, I really need to do that again because I used to feel a lot better than I do now, for sure.
Yes, it's good time invested because also, even for normal people, the times that you spend at the gym or to exercise for yourself, you gain it by being more focused, more, better in the rest of your life. It's also known to have anti-anxiety effect, antidepressant effects. It's because it also activates the stress axis. So in some ways you just, like we all are born with a certain amount of stress because we have been used to having lions or bad bosses, No, I'm joking, but at least a lion. And then now we are not so stressed anymore. So our things have to stress itself for no reason. And the sport, I think, activates your HPA axis and helps it to regulate that.
Very interesting. At least I still golf, so I got some sort of exercise.
No, golf is, I play golf.
Yeah.
Too.
You do?
Yeah, when
Oh, we
I
have to
was
play
young,
sometime.
Oh no, I will be like.
Are there any questions from the audience? Yes.
I have two questions. One is, could you share your tricks for dealing with nausea from Xyrem? That's the first question. And the second is, exercise is important, but if you also have POTS, I can't remember all the words for it, that limits your ability to exercise because of tachycardia, what do you do? Because if you're too wiped out because you tried to do some exercise and then you can't do anything for 2 days, how do you do exercise?
So the first thing is the treatment for. So of course, when I first realized this problem with nausea, and I had a couple of patients where it's delicate, so they lose too much weight, they become, especially if they are already a tendency to be rectic, which is normally not a problem. Usually patients are rather overweight, but you see everything, of course. And so I try things like Zofran that you use for people who have treatment of nausea is when they're doing chemotherapy. Didn't work at all, nothing. And then I tried another one that's called Periactin, which is cycloheptadines, and that works like incredibly well. You take it at night, like 2 milligram to 4 milligram, and that really gets rid of a lot of the nausea. And then often the problem of nausea, it's also something that's self-fulfilling. The more you have nausea, the more you have nausea. Because, after a while, there is like a sheath effect, you look at your Xyrem, it's normal. So you have to break that vicious circle. So very often you only use it for a while and then it gets better and that's fine. And also decreasing the dose, of course, can help. For exercise, again, I don't have a pill for exercise and people who are physically limited. I mean, the only thing I could say, and I just don't have a solution. I mean, I would say is that in cases, of course, you can try to do exercise that are less impactful on your body, like in swimming pools, etc. But that's just not something I'm very specialized in. And then there is a problem of some people who are intolerant to exercise, especially if they have some form of a bit like fibromyalgia or chronic fatigue syndrome. Some people are very intolerant to exercise and they need graded exercise. And sometimes there is overlaps with narcolepsy type 2. So that's a kind of a different whole ball of wax that needs to be probably looked at a bit differently.
What is Xywav an alternate medicine for Xyrem for the nauseous?
No, it's really the same. Usually it doesn't make a big difference, but that's a good question. I don't think it has been studied like really, really well. So it is possible that there could be small difference. The main difference between Xywav and Xyrem is how fast it goes into the blood. Xyrem really goes high, very, very high, very quickly and drops faster. Whereas Xywav is a little bit more like Xyrem with food. So it kind of goes up a little lower, but longer, lasts a bit longer. So it's possible since nausea, it looks to me like nausea are not directly proportional to the blood levels, because often even nausea with narcolepsy occurs the day after. So I'm not sure that.
I asked because I did meet someone at this conference that said she didn't tolerate the Xyrem at all. She was so sick and nauseous.
You saw
And
someone-
and then they switched to Xywav and it's perfect.
So I mean, again,
Everybody's different, right?
exactly. I mean, again, that's also like, I mean, you have, in medicine, you always say you have rules and always exceptions, you know, like even like narcolepsy with this HLA marker, it's like incredible. You know, I'm like, God, I see a patient, I know this completely clear narcolepsy. Say, boop, it's going to be HLA positive. And every time in the last 15 years, I've been right. Boop, HLA positive. But I know like 15 years ago, there was a couple of cases that I saw that was boop, HLA negative. Even so, they had low hypocretin. I mean, I'm talking about people when you can actually measure the levels of CSF hypocretin. So, because there is also cases where you're not sure of the cataplexy, then it's a little bit more difficult. So for those, sometimes they have low hypocretin, sometimes they have normal hypocretin, but otherwise it's fairly stereotyped. But still, you know, we found some people who don't have the HLA marker and have low hypocretin, and I have, you know, probably nine have been described in the entire literature. Probably there's a few more that I've not studied, but it's really rare. But they exist. There's always an exception. I mean, medicine is never 100%. It's humans are so complicated that it just doesn't exist something that's 100%. Anyone that will tell you that is a fool.
Interesting.
So Nicole and I were talking earlier about things that we could do that doesn't seem to have our narcolepsy effect. We got type 2. And I was saying that I could play a video game for hours on end without having any problems. As soon as I stop, I'm out. But I could play video games for 6 hours straight with no problem at all. Didn't know if there was any studies in that kind of a thing of what, if there's anything that, you know, doing this activity works really well, why, and not anything else.
I don't know if there's any specific studies, but for sure I have a lot of patients who, when they do things that are very intense and engaging, they kind of inhibit their narcolepsy. And I think you heard Nicole a little bit with this trick, you know, like if you're really concentrated and focused on something, sometimes that can keep at bay the narcolepsy and the cataplexy. And for example, I had children that were like doing dancing, you know, like ballet. And I mean, you would say, my God, you know, they could just collapse, you know, it's so, and no, she was doing perfectly well. But then after, very often just going out, you know, and the release, boom, they will have cataplexy. So cataplexy is very strange. It can definitely be kept at bay, and sleepiness also, it can be kept at bay for a certain period of time if you put all your energy into it. And yeah, so it's not surprising. Even so, I can tell you that some other people would fall asleep with, you know, it's not like everyone with narcolepsy wouldn't fall asleep doing a video game. But I think that's another interesting thing. There's this misperception, you know, in the public that we have to fight that narcolepsy is people who fall asleep riding a bicycle, you know. No, I mean, people with narcolepsy fall asleep when it's damn boring, you know. That's what happens. It's much worse when it's boring. I mean, falling asleep in a bicycle, okay, yeah, maybe I've never seen a patient, but, you know, of course, people with narcolepsy, their main problem is when it's boring and they have nothing to do. If it's sometimes it's during class, during things where they should be a bit engaged, but it's generally still when nothing is happening, it's not different from normal sleepiness, it's just worse. And people have this misconception that to have narcolepsy, you have to fall asleep, you know, I don't know, dancing, you know, I mean, that doesn't happen. So I think that's another important thing to realize.
I have a couple related questions. Why do you think that the number of sleep neurologists that will see pediatric patients is limited And what diagnosis tools are currently available for pediatrics, and what is there anything new being developed or that you hope could be developed for pediatric diagnosis?
I can answer that one because I have a guilt of myself because I've always wanted to go to the American Pediatric Association, you know, and try to give a major lecture about narcolepsy. I'm sure that it will lead to tons and tons of pediatrics, you know, pediatrician, even not pediatric neurologists, just pediatrician. I mean, if you have to assume that most pediatricians see several thousand people in their lifetime, so they must see a narcoleptic patients many times, you know, in their lifetime. Not like often, but I'm sure they do see, you know, probably 10 narcoleptic in their lifetime. And they just miss them. I mean, there is no doubt about it. And I think that's really something I feel strong about it. So I wish that we would educate better as a pediatrician. And there are some places in the country, I have no idea, there's some pediatrician, they know narcolepsy, and they send me like narcoleptic after narcoleptic after narcoleptic. So normally I think any pediatrician should see narcoleptics. And I feel guilty because I have some friends that work in this area, and I think I could have, you know, it's all kinds of paperwork. You know, someone would have to pin me down and make sure that, you know, I do the email to the people that matters to make sure they invite me and blah, 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 blah. And I'm not very good at following up sometimes, you know, but I think it would make a big difference. We need to figure out a way to educate pediatrician and pediatric neurologists. That's even more rare. But I think even just simple pediatrician, I think would make a big difference. Yeah. And because I think it's criminal to miss a patient with narcolepsy when they're young, because that's the formative years and never completely recover. And then if they gain a lot of weight, sometimes their confidence is completely shattered. It can really just be terrible. I mean, it's just unacceptable. So I really feel strongly. And also it's so fantastic for a doctor like me. I'm not a pediatrician, but I have pediatrician envy, I have to say, because I see patient kids and it's just so incredible when you see this child that sometimes, you know, come from being normal to being like completely destroyed, gain weight. And then people cannot do anything. And then you transform them back into normal. I think it's just something that as a doctor, it's just, you feel so amazingly good that, yeah.
So hi there, Dr. Joanna Reed. I'm a pediatric sleep neurologist here in Seattle at Seattle Children's. And so I had a question, but first comment that yeah, so much of it is exposure. And I had the good fortune of seeing Dr. Mignot speak. I figured it out, must have been 19, 20 years ago in medical school. And so that does influence you down the line, just knowing what actually exists and what's out there, that I didn't even know sleep medicine was a field until that lecture or until that course. And, you know, in terms of exposure, like in our own program in child neurology, after I went through sleep medicine training and became an attending, then the next, I think 3 out of 4 years, something like that, one of our child neurology residents each year went into sleep medicine. So it is just, you know, awareness or exposure. So we'll keep it up. My question though was for venlafaxine. So when I know it's listed for indication as for cataplexy, but I keep finding anecdotally time and time again that when I prescribe it for the cataplexy, that alertness also improves. And I'm just wondering, is this just luck of the draw, or is that something that you've been seeing as well?
No, it's because it's both norepinephrine and serotonin. It has a mild effect on wakefulness as well. And so, no, it's totally true. It's also a little bit stimulant. So that's why it's also a good antidepressant, better than anafranil or, you know, I think it's one of the best for cataplexy, but it's also wake promoting. And I always give it in the morning. And it's very important to give an XR because the regular medication doesn't last long enough. But, you know, probably you know that. Otherwise, you know, people get rebound cataplexy in the evening. But I think it has a good, yeah, it makes you more awake and it helps the cataplexy. Yeah, you're absolutely right. That's totally true. Whereas if you use Prozac or a pure SSRI, they don't have that much wake promotion.
I'm on venlafaxine. I've been on it for probably over 20 years, and it's definitely wake promoting. I take it in the morning, and I'm really good to go for a while.
But it's rarely enough by itself. Okay. I mean, I think.
Oh, no, I'm on other stuff too.
Yeah.
Xywav and Sunosi.
Without sodium oxybate, you just a little bit add up.
I've got a comment and a question. Since you've been around a little bit, Doctor, I'm curious. I self-diagnosed in the summer of 1984. 2 a.m. in the morning, there was a commercial, a PSA, on behalf of the American Narcolepsy Association with Bob Hope, the comedian, who describing the symptoms. And I was like, oh my God, that's me. And so I'm curious if you ever, if you recall that PSA.
So you think I should be a comedian?
No, I just,
I have a circus dog. So actually, it's interesting you say that, but still, I would want to mention that I know narcoleptic patients in Germany, in Berlin, with the sister of someone that was in my lab, and her father is a very famous journalist, but she's actually doing a comedy show about narcolepsy, and she herself has narcolepsy, and it's pretty actually seems to be quite popular. So that's just for you to know that. I think we need to, we need to find a way to reach patients with narcolepsy independently of doctors. I feel strongly about that. And I have had many discussions, when I first started to work with drug companies, it was first Cephalon with modafinil. You don't know, but when I was actually came to the US, I brought modafinil from France, which was a French drug, and was actually first tested in the dogs and then became a medication in the US. It was bought after, in France, and it became a US medication, very famous for narcolepsy. So I brought that in my suitcase. And but now I think it's a time, and this all the time over, they wanted, we have to give these questionnaires about cataplexy to all the sleep doctors, and we have to educate the sleep doctors to recognize more narcolepsy. They see sleep apnea, they miss narcolepsy. Yes, you get a few patients, but it's not the way to really find the patient with narcolepsy. We need to go straight to the population. The problem is you can't ask every GP to ask about cataplexy. I mean, they will say you are crazy. Already when you are yourself a patient, a doctor, asking about cataplexy is also an art. You don't want to just tell them what they have, because then they say, yes, I have it. And then you ruin your diagnostic potential. So you have to bring it, what's happening when you are in emotions, and little by little, you try to get them to tell you a story. And then you realize that becomes very clear. But initially, some patients, that's one of the most satisfying. They just realize suddenly that the question you ask, they know what you have. Then it's like, nobody asked me that specific question. That's a treat when the patient realizes for the first time that someone knows what they have. So it's difficult to ask, we will never get GPs or even sleep apnea specialists to always ask about cataplexy. Never. It will never happen. So my opinion is what you need to do is to go straight to the population, and everyone has a sleep problem. I mean, it's very simple. Everyone has a lot of sleep apnea, a lot of insomnia, restlessness. There's a lot more problem for sleep problems. I mean, we heard about the comorbidity with depression, etc. So there's a lot of sleep problem out there. So I think you have to ask, I've started to design this like a general questionnaire of like 20 questions that kind of ask about the main problem, and then and just squeeze in a question about cataplexy. And then if people have a sleep problem, they come and then they do all the thing, and then most of them will have sleep apnea, and you give them something if they have sleep apnea. Many of them will have insomnia, and you tell them what is insomnia. Many will have REM behavior disorders, and then a few will have cataplexy, narcolepsy, and you find them this way. I think it's a better, now more and more you can go straight with all this new media. We have to try to squeeze the doctor out of the equation. So you had the chance of having a comic tell you about narcolepsy, but maybe the chatbot will tell you about narcolepsy next time.
Possibly, or Gus Van Sant,
Yeah.
in his, My Own Private Idaho movie.
Yes.
It's, River Phoenix's, depiction of cataplexy was quite good, actually.
Yeah, I know. I've seen the movie. A couple, it's
Thank
better
you.
than the rat race, you know.
Yeah.
Thanks. We have about 2 minutes left. Wanted to ask you about how you have coped with different jobs and if you can share some tips on how to do well in in your career and in at different jobs.
Yeah, so, when I was playing golf for a living for all those years, I never thought I could actually have a real job. And I thought I have to keep on playing this game. A, I loved it. I loved competing. But B, I was like, I have to take all these naps during the day. So, I would like play golf and then I would take a nap, then I would practice, then I would take a nap, and then I would, but I was my own boss. And so I thought I was going to have to live like that forever. But, with all the medications and feeling better, I was actually, when I quit playing full time, I took a teaching job, and only part-time, because I wasn't sure I could really handle full-time because of napping and that. And so I still nap in my car all the time. But it's okay. And nobody even knows it. I just go out there and nap. I mean, other people go have lunch. I go to my car and sleep. And I wake up and I go back to work and everything's great. And now I do work full time. But I take Sunosi, and that I can go a whole day without a nap with that Sunosi drug, but my insurance is not covering it. So I got to figure out how to get the insurance I'm working on external review or something. But eventually, hopefully they will, because I feel better with it and I think better. I can live without it, yes, and take more naps, but I think better. I give better golf lessons when I have that medication. And I talk about my narcolepsy openly. I don't advertise it, but I'm happy to answer questions when my people at work ask me. I don't think anyone's ever like found me in my car sleeping and go, "What are you doing?" If they did, I would just be like, "Oh, I'm taking a nap." And like people are so much more patient and open to different things these days. I mean, 20 years ago, that was not the case. They looked at you with 4 eyes when you were saying you were taking a nap in your car. But now I think it's really, people are pretty kind of cool about things. So we live in a better day and age for sure. Did that answer your question?
That said, there's also some very tough stories out there about narcolepsy. For example, where I have some single mothers that have kids and they have narcolepsy, and sometimes it's really tough to be effective when you have already a tough life and narcolepsy. It's just everyone has to find his solution, but sometimes some people start from a very bad and difficult background, and it's really hard for them to find a solution. I still feel really bad sometimes when I can't really I just can't fix a social problem, I can try to get the narcolepsy better, but it's a social issue. It's very difficult.